Hello nurses, good evening. Happy to see you all here on our makeup class. It's hard sometimes, we have a very busy schedule, but I'm glad to see a few of you made it out today. This recording will be forever held in posterity on my YouTube. And forever in posterity is probably about a few weeks. So make sure if you want to review it over the next few weeks before it disappears forever. So today we are going to start off by talking about some NCLEX test taking strategies. I feel it's only fitting, since this is our sort of last week together, to discuss NCLEX strategies, some of the things that I've curated from Kaplan, from various YouTube videos, a bunch of different sources. I sort of put it together and made a nice presentation for you all, sort of passing on some of the best strategies that I found for taking the NCLEX, how to approach, select all that apply questions, priority questions. Really the tougher questions on the NCLEX are those two, so we're going to talk about that. When we finish that, we're going to get into mental health. And mental health is an area that there are a good number of questions on the NCLEX, and so we'll go through that and see what we need to know there. Before we get started with all that, we have a question here, sort of relating to what we finished off talking about last time with our diabetic ketoacidosis and our patients with insulin. And so take a moment to read through this question, and then whenever you're ready, you can go ahead and drop an answer in the chat box and let me know what you think the best would be to do for this client with DKA. If you have some idea what you'd like to do, you can go ahead and drop it in the chat box. If you're still thinking, that is okay too. So, let's see. We have an adult client experiencing DKA admitted to the emergency department. Which of the following interventions should a nurse initiate immediately? And so what we're going to talk about today is how to reframe questions. If I was to reframe this question, I would say, what do you need to do with the client in DKA? Okay, and so number one, administer oxygen. This is not something that's really necessary for DKA. This I would call false. Right? Because clients that are in DKA, they actually have plenty of oxygen. If you see a client in DKA, they are going to be taking deeper breaths than even your healthy clients. They take these very deep breaths in order to try and blow off some of that extra acid. When we did our pulmonology section, we talked about how carbon dioxide is a major acid in our body. If you have some sort of acidosis, your respiratory system will compensate by breathing more rapidly, more deeply, to try and blow off some of that carbon dioxide. So this is false. We're going to take this one out. Administer D5W with normal saline after establishing IV access. Now, when we have a client in DKA, how high is the sugar? Is the sugar usually in the 100s, 200s, or much, much higher than that? So a typical sugar for someone in DKA, you can see anything 500 plus. Matilda says 300 to 600. I tend to agree with her. 300, 400, 500, 600, 700 even. These are the sugars that you're going to see in someone with DKA. If you have someone with a sugar of 500, do we need to give D5W? Probs not, right? Probs not. This one we can skip because they have enough sugar already. We do not need to give D5W. As we administer insulin, that's something that we're going to be doing soon, right? As we administer insulin, this is going to start to drop. However, you don't really need to start D5W until the insulin is under 250. But if your client is in DKA, I can pretty much guarantee you the sugar is way over 250. My guess would be something closer to 350, 450, 550, something like that. Okay, so once we get under 250, you can start adding D5W, but until then, we're going to not be giving that. Initiate a regular insulin infusion. Insulin infusion is going to drop the blood glucose. It's going to relieve some of those symptoms of DKA because now we are getting that glucose into the cells. We're getting the glucose into the cells. And so, since the glucose is into the cells, we're going to stop breaking down fats to create acid. We're going to really decrease DKA, and your client is going to start feeling better right away. And so, initiate a regular insulin infusion. This is one of the very basics of treating DKA. Determine the time and amount of the last insulin injection. This can be important as well. We have someone who has, a history of diabetes. When was the last time they got insulin? How much did they give? What is their normal regimen? This is an important thing to figure out. Potassium and magnesium to correct electrolyte imbalances. If we see the imbalances, we can correct them. However, we don't know if those imbalances are there yet or not. And so we're going to skip this for now until we're able to get some sort of monitoring of the level of the electrolytes. We can't really give those quite yet. We need to be able to take labs before we take on one of these things. Assess the client's breath for ketones. Not terribly important. We already know that they're in DKA, and so we do not need to look for ketones. Okay, very good. So our answer here is going to be 3 and 4. Moving into our NCLEX strategies here, the road to passing. So, some of you are taking your test soon. Some of you still have some time before you're taking your test. Hopefully you have enough time to sort of implement some of the things we're going to talk about today. We're going to talk about changing the way that you approach questions. What is your attitude towards questions? What's your attitude towards the exam at large? Because this is going to really influence how you're scoring. The basics of answering priority questions. There's a very, very simple algorithm and a rubric we can follow answering these priority questions that will allow us to really quickly eliminate some of the less likely answer choices and allow us to keep some of those answer choices that we like a bit more. So the basics of answering priority and how to improve on select all that apply. If there's a number one thing that my students come to me and ask me about, it's how to improve on select all that apply. And so this is something that we definitely need to talk about, right? It's a very common thing people want to improve upon, and so let's talk about how do we do that. So starting off with the things that the best test takers do, getting into what are the things that we can change about our approach to the exam. So the best test takers have a good understanding of nursing content. There's just no way around this. This is not a recite basic facts type test. This is not what we're expecting you to do, to just memorize basic facts, but you do need to have a good understanding of how different facts influence each other, how the treatment of this particular disorder differs from the treatment of another disorder, okay? And so I'm just going to pause for a second. There's a few people that are emailing me to ask for the link, so I'm just going to forward that link to them. Just a minute. It's the same link, just so everyone knows. Every time we meet, it's the exact same link. So if you just bookmark it in your browser or just save it, you'll be good to go. Okay. Okay, hopefully they can make it in and meet us now. Great, so having a good understanding of nursing content, no way around it, right? Next is attacking each question with the confidence. Good test takers feel like they can figure out the right answer. Even when it's something that they're not totally comfortable with, even when they're introducing new terms, new topics that you don't really remember that well, having that confidence of saying, you know what, I don't remember this topic, but I have the ability to figure out this question nonetheless. If I can't figure out the question, I can at least improve my percent chances at getting it right. Every single question, that should be your mentality. This question, I don't really remember when they talked about pheochromocytoma. I don't remember when they talked about the risk factors for, colon cancer in adult men. But I know that there are things that don't make sense here. I can eliminate those and really have a better chance of getting the right answer. And so these are the sorts of things that you should be doing on every single question. Spencer, I see that you made it in. Glad to see you made it. Don't give up because you're unsure of the answer. And I've told you this many times before. Never throw your hands up. This is not a hip-hop concert. You should never be throwing your hands up and just saying, I don't know. If you're not sure of the answer, think about the question. Analyze the answer choices. Be critical in the way you're thinking. Be spontaneous. Think about these things in a new way and really apply yourself. If they're asking you about something you've maybe never heard of before, have that confidence to say, you know what, I'm not sure of this answer, I'm not super confident, but I'm not going to throw my hands up, I'm not going to give up, I'm going to try to apply myself to answer this question. Okay, it sounds basic, but this is real stuff. This is what great test takers do. Possess the know-how to correctly identify the question. What do we mean by this? Correctly identify the question. It's that long sentence at the beginning, right? It's towards the top of the page. What we mean here by correctly identifying the question is sometimes when you read a question on the NCLEX exam, the words that you read are not actually what the question's asking you about, right? Sometimes they will sort of hide what the real question is behind layers and layers of unnecessary information. And so in order to identify the question, you need to be able to reword that question in your mind. They're giving you all this information on all this lab work and all these vital signs, and then they finally get to the stem of the question. Being able to reword everything they gave you, boiling it down to just the fat that's left over. What is this question actually asking me? This is what good test takers do. And guess what? This is what every single person that's here in this tutoring session can do. Anybody can do this, right? All it involves is reframing the question, and we're going to talk about how to do this. Staying focused on the question, not being led astray by some of the extraneous details. When they're talking about a client who had a history of this, and that, and now they're presenting because of this, don't get distracted with that history. Stay focused on what the question is actually asking you. Don't follow the rabbit down the rabbit hole of all this extra extraneous information. So if this is what good test takers do, what do terrible test takers do? Assume that they don't know or cannot answer the question. They see a question on tuberculosis and they say, you know what? I remember I was terrible at tuberculosis. I remember trying to study that and I can never remember it. So you know what? I'm just going to guess C and move on. That, my friends, is how you fail the NCLEX exam. You should not be doing this. If it's a topic that you're not familiar with, if you're getting stumped on it, you should still have the ability to make your best guess. Okay? You all have studied a lot. You all have really, been here in this class. Outside of this class, I'm sure you've been studying, doing practice questions. You're applying yourself. And so, chances are there's some nugget of information lodged back there in your brain somewhere. It might be covered in dust and cobwebs, but that nugget can help you get to the answer of your question. So never, ever just assume you don't know the answer, because you at least have the ability to make your best guess. Memorizing facts is not a realistic strategy for the NCLEX. Like we talked about, this is a logic-based exam. This is a practice-based exam. This is you applying your judgment to different scenarios, and they're going to judge whether or not that's the correct movement to make. Simply reading the question, moving to the answers, reading the question again, and then picking an answer is not an effective strategy. This is probably the way that many of you are approaching your questions. You read the question, read the answers, read the question again, and then just pick an answer and move on. At no point during this sentence or this strategy did we take a moment to eliminate. Did we take a moment to critically rethink the question? At no point did we take a moment to apply ourselves and our understanding to the answer. Here we're going with our gut, we're just making our best guess, which it's not a good strategy. In trying to pass the NCLEX, you want to get every single percentage point you can get of passing, right? If you are guessing on every single question for the NCLEX, every single of the 270 questions, you have probably about a 20% chance of passing, right? If instead you're making educated guesses on every single question, that would increase to 50%. If you are getting a number of questions right and then making educated guesses on the rest, now you're in 60-70% chance of passing. Okay, is this making sense? You need to be applying yourself and really critically thinking about every single question. If you feel yourself starting to guess on questions, it's time to take a break. At the next opportunity, take a break, go out into the hallway, tell yourself, I'm not trying to take the NCLEX again. I don't want to go through this process. It's stressful. I hate it. I don't want to do this again. Let me go back with this new attitude. I'm going to make my best guess on every single question and then maximize my chances of passing. Answering questions based on personal experience. I'm sure you all have excellent personal experiences being in the hospitals. You had a cousin who was in the hospital one time, you visited him, and this was your experience. Great. I'm really happy for you. Don't use that on the exam. okay? This needs to be based on nursing theory. The things that you read in your books, the things that we talk about in this room, these are the things that you're basing your answers off on the NCLEX. Not something you saw some LPN do one time, okay? Not only may that be the wrong thing, but on top of that, you don't know if that situation that the LPN was doing that thing that you're remembering is the same exact situation as this question stem. There could be little differences that could sort of lead you astray. And so if you find yourself going back in your mind about, times you're in the hospital, what did they do, try and bring yourself back into the world of NCLEX. If that's sort of the way you remember things that you study for NCLEX, that's fine. Like I always remember to give insulin to DKA patients because I saw a DKA patient, and then we talked about it in class, and now I know that. That's fine. In that sort of context, that's okay. But basing your complete answer off of something you saw one time in the hospital, not a good strategy. Okay? Giving up too soon. This is what happens to anyone who has to answer 270 questions in a row. And so my advice to you is don't do that. Take scheduled breaks. Be kind to your brain. Your brain does not like answering 200 questions in a row. Be kind to your brain. Take regular breaks. Yes, it's going to make your day longer. You're going to end up having to, be at the testing center longer. And who wants to be at a testing center? That's okay. Take those breaks. Make them count. Really decompress yourself during that break. Get a drink of water. Pound an energy bar or a Red Bull. That's fine. But then get back in there and do your thing. Okay, and also you got to stay focused on the question. Terrible test takers do not stay focused, but I know none of you suffer from that, so I'm happy to hear that. Always do these two things, okay? If you zoned out on the last slide, it's time to come back because these are the two things that we're going to be talking about today. Number one, figure out what is this question really asking you. NCLEX questions are full of fluff, full of pizzazz. Really, they're throwing all sorts of vital signs and names of different disorders at you that you've never heard of. What are they actually trying to get at? Because the question writers know that you are studying from the same book that they're making their questions from. And so they try and jazz it up. They throw new things at you to try and confuse you. In order to get through all that BS, to boil down that milk into just the fat, you need to be able to reword the question in your mind in its simplest form. What do I mean by this? We're going to practice it in a minute. Number two, eliminate answer choices. We've said this time and time again. You should be doing this on every single question. Every single question, at least eliminate one of those answer choices. You're increasing your percent chance of getting that question right by 12% each time you do that. Okay. Wonderful. So we have a question here. Before you go to your answer choices, don't worry about the answer choices. I wish I could block these out actually. Don't even read the answer choices. I want you to read this question stem and then reword it in your mind for what the question is actually asking you. Okay, so take a few seconds to do that. So we have a physician ordering ABG for a client receiving oxygen at 6 liters per minute. Results show a pH of 7.37, bicarb of 26, PCO2 of 42, PO2 of 90. Which of the following should the nurse do first? I see people already answering. And here's the thing. If you're already answering, you didn't take the time to reword the question. So rewording this question, I'm going to look back at these ABGs and see if they're important. So results show a pH of 7.37. Is this normal or abnormal? Is this within our normal range or is it outside of our normal range? Normal, excellent. pH is normal. How about the bicarb? Normal or outside the normal range? Normal again. PCO2, normal or outside the normal range? Normal. Pressure of oxygen, normal or outside the normal range? Brielle says outside. It's right on the border, right? So our normal oxygen is from 90 to 100. And so by our technical standpoint, a pressure of 90 is normal. We don't like seeing 90. We want to see it higher. But for the sakes and purposes of the NCLEX exam, if you see 90, you need to consider that normal. Okay? Anything in the 80s would be a little bit abnormal. And so if I'm rewording this question, I'm going to say, what should a nurse do if she sees a normal ABG? What would a nurse do if she sees a normal ABD? Adabisi changed her answer when I said that, right? Priya, Caitlin, yes, I agree with you. If you see a normal ABG, you're just going to document it. If you don't take the time to reword these questions, you're going to be led astray. You're going to be seeing this, that, so a little bit confusion, and then start wanting to do some sort of intervention here. Okay? Take the time to reword these questions, and it's just going to clear out all the BS. You hear someone is receiving oxygen at 6 liters, it's like, oh my God, this guy, he's probably got pneumonia, he's got COPD, he was in a car accident, and his mama's not feeling well, right? Your mind starts going down this tract, and you don't want to follow it there. Just look at what is really relevant here. We've got an ABG showing normal blood gases. What should you do? Document them and keep it moving, okay? Questions on this? No questions. Excellent. So we're going to practice this throughout the day today. Every question we do, I'm going to ask you to reframe the question for me before we go into the answer choices. Okay? So moving into our select all that apply questions, you all know these. Anywhere from all of the answer choices to just one answer choice can be correct. What I'm going to recommend that you not do when you get these questions is comparing and contrasting the individual answer choices. We spoke about this a little bit yesterday, and so now we're really going to get into the nitty-gritty. Comparing and contrasting the individual answer choices is going to confuse you. You're thinking, well, I already did answer choice A already, so would I do answer choice C now? No, that is not what select all that apply is about. Select all apply is, would you do this, yes or no? Okay, we're not doing this in order. We're not, we have ordering questions, right? We have to put things in order. Those are hard enough. Let's not add that into our select all that apply. Each of these are their own question. Treat each option as if it's its own true or false question. Taking your time with every single option and making sure that you're treating it as if it's its own question and giving it the respect in that way. Okay. So we have a question here. Before we get into the answer choices, I'd like you to read through this question stem and then reword it as best you can for me, okay? Before we get into the answer choices, read this question stem and then in your mind, reword this question so it just boils down to what is most important. So here we are caring for a client with a right-sided cerebrovascular accident, aka a stroke, right? With dysphagia. Dysphagia, what is dysphagia exactly? Can someone remind me what is dysphagia? Because there's a little bit of confusion out there about dysphagia and something called odynophagia. Odynophagia. So what is dysphagia? What's odynophagia? Before we get into rewording this question, we need to sort of establish this. Difficulty swallowing, trouble swallowing, unable to swallow, wonderful. This room has a bunch of superstars, no confusion here. And so dysphagia is an inability to swallow or trouble swallowing versus odynophagia. What's odynophagia? Odynophagia is pain. Yes, Namrata. Pain when you swallow. Odynophagia is when you're swallowing, you have pain. Think about when you had pharyngitis that one time and you tried swallowing something and it was like swallowing sand. That's odynophagia, is pain. Dysphagia is trouble swallowing or it's difficult to swallow. And so one of our concerns with dysphagia is something called aspiration. Food, instead of going into the esophagus, goes into the windpipe, gets into the lungs. The lungs cannot handle food, and so we end up with a serious bacterial infection in the lungs, okay? Not good. So anyway, going on with our question here, which of the following actions by the nurse reflects appropriate care for the client? And so having read this stem, thinking about what's being asked here, I would reframe this as, if I have a client who has difficulty swallowing, what should I do for them? Even better, If I have a client who has difficulty swallowing, how do I prevent aspiration? That would be just like the, oh, beautiful pinnacle of this question. Because what the NCLEX is asking about here is not about strokes. It's not even really just about swallowing. It's about preventing aspiration, because that is the job of the nurse, right? That's really what they want to get after. They're going to throw these fancy words at you, right-sided cerebrovascular accident. They're asking about aspiration risk, okay? And so let's really talk about aspiration risk. So looking at some of these answer choices, take some time looking at these answer choices, formulate your answer. Whenever you're ready, you can drop it in the chat box. No need to wait for me. And then once a few of you have responded, then I'll go ahead and then we can go ahead and talk about it. Okay, definitely some answers coming out here. Great. So if we're worried about aspiration, should we check the nurse's ability for the client to swallow? Absolutely yes. We need to check that because this is going to inform the rest of our decision making in terms of what foods to give and everything else. So true. I like this. I like this. Now, nurse positioning the client at a 45-degree angle. Okay, so if I'm thinking about the different positioning, I'm thinking about fowlers and semi-fowlers. 45 degrees are semi-fowlers, right? 45 degrees, if this is the foot of the bed, that would put the head of the bed about right here. Now, forget this guy with dysphagia. If you are laying down like this, right? Whether you're eating or you're just hanging out, do you feel like it would be easy to swallow? If you're reclining in your bed backwards like this, would that be a scenario where you feel like, you know, I don't have to worry about any food going down my throat? Not really, right? Even trying to drink while you're laying down. Have you tried drinking while you're laying down at 45 degrees? Not the easiest thing. 45-degree angle, we don't like this because this guy already has issues with dysphagia. 45 degrees, they're laying backwards, reclining. What we want is 90 degrees, or at least something closer. Maybe even 60 degrees would be better. 45 degrees is too low. Okay? Does that make sense? Why we don't like 45 degrees? A lot of you went for number 2, I know, because it talks about positioning. And positioning is important in, positioning is important in worrying about aspiration. 45 degrees is too low. Okay? So we're going to take that one out. The nurse offers the client scrambled eggs. This is asking, when you have aspiration, is it okay to give semi-solid foods? If you have a risk of aspiration, can we give semi-solids? A lot of you are saying no. In fact, you can give semi-solids. Yeah, you can give semi-solids. You cannot give solid foods, but things like scrambled eggs, mashed potatoes, Jell-O, things that go down really smoothly, these things you can give. If anything is a semi-solid, semi-solids are okay. Semi-solids are okay. Right? This goes in the same category as mashed potatoes, same category as Jell-O. Scrambled eggs, you know, are not particularly crusty unless you left them on the stove for too long. The nurse instructs the client to place food on the left side of the mouth. I see not many of you went for this one. I'm happy to see that. And so, why is this not right? What is wrong with this answer? Someone tell me. Boom. Yes, Caitlin. Excellent. If we have a right-sided stroke, that's going to affect the left side of the body. Right-sided stroke, left side of body. Left-sided stroke, right side of body. Say it with me. Right-sided stroke, left side. I'm just kidding. So whenever you have a stroke, it's always going to be the opposite side of the body that is affected. Okay? So the nurse instructs the client to place food on the left side of the mouth. That food is going to promptly leave the mouth, right? Because the client's not really going to have any control on that side. And so this is going to be wrong. The nurse turns off the television. This is getting after, again, you're thinking about what are the things that will increase your risk of aspiration. If you're trying to eat while you're watching Fox News, even I aspirate if I watch Fox News, okay? And so, if you have the TV on, you're trying to eat, that's a distractor. We don't want to have a lot of distractions in the room, so this is going to be good. We want to turn off the television. If we want to really limit distractions, we'll put this client into a semi-private room. We'll put this client even into a private room if it's available. We really want to limit distractions for someone with dysphagia because we don't want them aspirating. Okay, and so I have a comment here. Someone asks if, it's not really a question, actually, there's a comment. If you're assessing the ability to swallow, wouldn't you not want to give food because it can make the aspiration worse? You're absolutely right. However, we're not doing these in order. These are separate things. This is why we treat them each as a true-false. And I don't want you comparing answer choice to answer choice because this is how it's going to lead you astray. You're going to see the nurse assesses client's ability to swallow, and then you're going to see scrambled eggs. You say, whoa, well, I don't want to give scrambled eggs until I assess, right? These are all separate questions. Treat them like separate questions. Can you give someone with dysphagia semi-solid food? Typically, yes. Should you assess clients who have dysphagia? Yes. Should you limit distractions for someone with dysphagia? Yes. You're not doing these in order. You're doing them separately. And you are, that's the way you need to treat these questions because chances are you're missing some of these questions because you're sort of comparing and contrasting individual answer choices, sort of picking what you like and leaving what you don't. Treat them separately, and you're going to see that these questions get a lot easier. Okay? Great. Excellent question, though. Excellent question. Any other questions on this? Any other questions on this? It was a tricky one. I'm not going to lie. I'm not going to lie to you. This is a tricky question. But the NCLEX is not out to make friends with you. Okay? So don't worry. Some of these questions are going to be tough, but it's all for a good cause. Good. Excellent. So we have another select all that apply here. Before you get into these answer choices, go ahead and read through this question stem. Reword it in your own words, and then we'll do it together. So we have a nurse monitoring a client who's receiving a blood transfusion. When the client reports diaphoresis, warmth, and a backache, the nurse should take which actions? Okay, so before I jump into the answer choices, I need to actually understand what's happening. I've seen blood transfusions before, sort of tapping from my hospital experience, and this is not something that's normal with blood transfusions, right? Having diaphoresis, warmth, and a backache. I'm concerned about some sort of it almost looks like an allergy or some sort of reaction to the transfusion. And so in my mind, I'm going to treat this as if it's almost like an anaphylaxis, right? Diaphoresis, warmth, a backache, that kind of sounds like an anaphylactic shock type scenario. I don't know exactly what's happening here, but it really sounds like anaphylaxis. So I'm going to treat it that way. And I'm going to say, what should a nurse do in the case of anaphylaxis? Okay? Select all that apply. So with that understanding, go ahead and look through some of these answer choices. When you have an answer you like, you can go ahead and drop it into the chat box, and then we'll go through these together. Okay, so I'm going to start with answer choice number 1. Again, starting with my reformed question here, if I see a client who looks like they're having some sort of anaphylactic shock, would I remove the IV catheter? Probably not. The IV catheter itself is what we will use to administer drugs. If our client's going into shock, we're going to need to be pushing fluids. We're going to need to be pushing norepi or phenyl or what have you, we're going to be pushing some medication, dopamine, to bring that blood pressure back up. We're going to need that IV catheter. Lulu says no. I agree with Lulu. Let's not do number 1. Document the occurrence. Having some sort of allergy means that we want to make sure that, that allergy doesn't happen again in the future. And so documentation is an incredibly important job, for a nurse. I can see most of you went for this answer number 2. I agree with you. Number 2, we definitely need to document. Stop the blood transfusion. If I had a client who was getting a blood transfusion, they started getting anaphylaxis, would I stop it? Yeah, I think I would want to stop it, right? It seems to be the source of all of these sorts of symptoms and sort of the threat to this client's health are coming from this blood transfusion, and so stopping the transfusion. Not removing the catheter. We're going to leave the catheter there, but we are going to stop the transfusion. Contacting the primary healthcare provider. Well, if my client is going into anaphylaxis, I'm going to need orders for a bunch of shock meds, right? And so let's definitely do that. Hang normal saline solution. If I have a client who's having an anaphylactic shock, would I hang normal saline? Yeah, I probably would. Okay, I want to make sure we get that blood pressure up. So the answer here, 2, 3, 4, and 5. Seeing this diaphoresis, warmth, and backache really needs to sort of trigger in your mind, okay, I think that there's some serious side effect going on. When you're getting a blood transfusion, you really shouldn't have any symptoms at all except the pricking sensation when you place the IV. Having all of these symptoms, we are very concerned that there's some sort of hemolytic reaction going on, and we need to check that out pronto. Okay, any questions on this one? Some of the techniques that we talk about today, you're going to love it. You're going to start using it every single time you do a question. Some of them, you're not going to agree with it. You're not going to be a particular fan. That's okay. I'm sharing these with you because, I think that they're helpful. Other people think that they were helpful, which is why they, sort of wrote about them and how I was able to find them. And not everybody's the same. Not everybody learns the same. Not everybody thinks the same. That's the reason why we're all a little bit different, and why we're all special and unique, right? Matilda asks, what when they have chills? What about when they have chills? When they have chills, that absolutely goes after some sort of anaphylactic type reaction. Okay, the warmth that we're feeling is because all of the vessels in the body are dilating. The vessels in the body are dilating, and so our body heat is going to leave very quickly. Our body heat's going to leave very quickly. So expect to see chills shortly, right? They're going to initially be warm, and then the chills are going to come shortly after that. Okay. Good question, Matilda. So, a couple more select all that apply type strategies. These we discussed earlier when we met for the first time in February. Test-taking strategies. If two things are diametrically opposed, meaning complete opposites of one another, one of them has to be right. Some of these test writers, it's hard for them to resist making one thing wrong and then using the same wording for another answer choice, but giving the direct opposite. If you see two answer choices that are complete opposites, how can they both be wrong? One of them has got to be right. And so if you're seeing things that are opposite in these question stems, keep an eye out for that. This is really the only time that I would allow comparing and contrasting answer choices is if you have two that are complete opposites of each other. In that case, all right, yes, compare them because it makes sense to compare them. But in any other case, I really don't think it's a good idea to compare and contrast answer choices, to try and put some sort of chronological order on the answer choices. It's not a good strategy. It's not going to get you points on the board. So moving into our priority questions. When you do a priority question, as many of you already know, there's going to be multiple right answers. And the first thing to do is don't freak out. This client that you're seeing is going to have multiple problems. What they're getting after on these priority questions is, do you have the judgment to sort of act quickly in the moment? Do you have the judgment to, when you're talking about a client, when you're giving report to another nurse, giving that report in a way that makes sense? right? Say you have a client who has heart failure and toe fungus. Which one are you going to tell the nurse that you're handing off to about first? You're going to talk about the heart failure before the toe fungus, right? And so this is what we're getting after with priority questions. Do you have the ability to sort of, organize your thoughts, organize this client, and address the most important things first? Okay, but it can be tricky because we're seeing all these answer choices, which are things we would do, and we just sort of have to pick which one we would want to do first. And this is where Maslow's hierarchy of needs comes in. And I know you're all probably looking at this like, what the heck are you talking about, Maslow? This is not psychology class. Put that away. I'm borrowing this from Kaplan. Thank you, Kaplan. Maslow's hierarchy of needs is actually pretty helpful for the NCLEX exam, especially these first two steps. So for those of you that have not seen this before, Maslow's hierarchy of needs describes the things that we need in our life. Okay? In order to reach the peak of the pyramid, you need to have each thing under it. In order to reach the fourth step, you need to have each step under it. Okay? And so, in order to say have safety and security, you want to have, you want to feel secure in your life, you want to feel safe. You can't feel that way until you meet your physiological needs, right? Making sure that you have enough food and water, that you have shelter, that your own body is taken care of. That's your physiological needs. That's always going to come first. Safety and security comes second. And here is where we get into some of our psychosocial type things. How do we feel? What is our knowledge? What's our education? What's our understanding? These things are safety and security. That's where that falls. Once you feel safe, once you feel secure, think about the ancestors out in the wild, right? These are the things that they looked for. They were searching for food. If they found the food, then they could start thinking about safety and security. Then they could start thinking about having a relationship, love and belonging. When you hit that point, now that you have that belonging, you can hit that self-esteem, feel good about yourself. When you feel good about yourself, oh my God, you hit the peak of the pyramid, self-actualization. You are just someone who really feels great about what you've accomplished in life. And what's funny about this is if you apply this to your own life, you're going to find that this is true as well. If you're hungry, typically your loved ones are not going to want to be around you, right? Because you are not putting them first. This applies. This is a very real thing. And it also will help us on the NCLEX. I'm going to tell you how. So our physiological needs necessary for survival, they have the highest priority, need to be met first. Oxygen, fluid, nutrition, temperature, elimination, shelter, rest, and sex. And so these needs are always going to be the first thing that you address. If you're, thinking about priority questions, these are the things that we need to address first. Obviously, we can't do something for every single one of these categories, especially this one, we can't really address in the hospital, but everything else we should be able to hopefully help the clients out with. Safety and security, physical as well as psychosocial. Physical safety includes decreasing anything threatening the client. That threat can be someone threatening to hurt them, or it could be the threat of an illness with an MI. And accidents, like a patient transporting a newborn without a car seat. Environmental threats, a client with COPD who wants to walk outside in 10-degree temperature. This is our safety and security needs, and these are sort of the second step on the pyramid, the second thing we can address after we've addressed the physiological. Psychological safety is going to fall within this category. The client's going to need to have the knowledge and understanding about what to expect from others in his environment, what to expect from his illness, what to expect from his medications, what to expect from his therapy. All of these things are going to fall within psychological therapy. For love and belonging, client needs to feel loved by the family and accepted by others. When the client feels self-confident and useful, he will achieve the need of self-esteem. So these two we're not really going to address in terms of our priority questions, right? We can't really help our client feel love and belonging necessarily, and so those two we're not really going to worry about. But physiological and safety and security needs we can definitely use on the NCLEX, okay? And so we're going to use it in a stepwise fashion. Step 0, which is not listed here, and I need to add it in. Step 0, we are going to reform the question stem, right? We rewrite the question stem in our own words. Okay, I'm going to write reword stem. We are rewording that stem in our own words. Okay, sorry, I cannot spell today. We're rewording the stem in our own words to really get at what the question's asking us. Once we've done that, we can move into, we understand that it's a priority question, we can apply Maslow. So look at our answer choices and see if we have a mix of physiological type answer choices and psychosocial type answer choices. If you do see a mix, congratulations, you get to move on to step number 2. Step number 2 is eliminate every single psychosocial answer choice. Psychosocial is never going to be more important than physiological needs. When you're getting these priority questions, what is the best next step? What is the nursing priority? And you see a mix of physiological and psychological, eliminate anything that's psychosocial. Okay? The physiological always needs to be met first. So pain, you think about that as maybe it is somewhat physiological, right? You can have an increased blood pressure or pulse. Really, for the purpose of the NCLEX, pain is considered psychosocial. And so this is another thing that you could eliminate. All right? Once you've done that, look at all of the answer choices you haven't eliminated. Make sure that they make sense in regard to the question that's being asked. And then apply the ABCs. If you can apply the ABCs, then go with that answer choice. It makes sense, and you can apply the ABCs, and it's not psychosocial. Great, that's your answer choice. If not, then you have to do a bit of figuring out and see which answer choice you like a bit more. Okay? So, why don't we give this a shot? So we have a question stem here. First thing we're going to do is reword this stem. So just go ahead and read through this stem. I'll give you a moment, reword it in your mind, and then we'll go through it together. Okay, so we have a woman admitted to the hospital with a ruptured ectopic pregnancy. Okay, not good. A laparotomy is scheduled. Laparotomy, this surgery, if you're not aware of it, involves taking a scalpel, inserting it into the abdomen, and dragging it along the abdomen until you've completely opened it. Okay, in a laparotomy, we are opening the abdomen. It is an open abdominal surgery. Don't get it confused with laparoscopy. In laparoscopy, we just insert little cameras into the abdomen and then sort of look around and see what's going on. Laparotomy, we're actually opening up the abdomen. So this is a big abdominal surgery, right? Preoperatively, which of the following goals is most important for the nurse to include on the client's plan of care? We're thinking about a client. If I was to reword this question, I would say, if my client is going to have an open abdominal surgery, what is most important for that client? Okay, so we've reworded it. Great. Step 2, eliminate every single answer choice that is psychosocial. And so, fluid replacement, not psychosocial. Pain relief, is pain relief psychosocial or is this physiological? Eliminate or don't eliminate. You can just drop it in the chat box. Are we eliminating 2 or not eliminating 2? Eliminate. Eliminate it. Yes, pain relief. Not as important as anything else. Emotional support, obviously, this is going to be psychosocial, emotional support. So we're left with fluid replacement and respiratory therapy. The next step as we are working through this, after we eliminate, now we look at the answer choices we haven't eliminated. Ask yourself if the answer choice makes sense in regard to the disease or situation described. So our 2 answer choices here, fluid replacement. Okay, in open abdominal surgery, we're definitely concerned that this client's going to be low on fluids, either from bleeding during the surgery or from the ruptured ectopic pregnancy. For whatever reason, there's going to be a need for fluid. So that one makes sense. Respiratory therapy. Well, the ovaries and the fallopian tubes are not anywhere near the lungs. And so I don't anticipate there being any need for respiratory therapy. This one doesn't really make sense, and so we can go ahead and take it out. All right, and that's going to leave us with fluid replacement. So, using Maslow, you can see it's really just the goal of it is to help you eliminate some of the answer choices that seem a bit iffy sometimes. And in cases where you have a priority question, if you see a mix of physiological and psychosocial, eliminate all the psychosocial and then go from there. Okay, it works too. Trust me, when I first read about this, I thought it was bananas, it was bonkers. I thought it wouldn't work. It actually works pretty well. So let's go ahead and try that again. If you can just read through this question stem, go ahead and reword it in your mind, and then we'll go through it together. So, here we have a nurse obtains a diet history from a pregnant 16-year-old girl. The girl tells the nurse that her typical daily diet includes cereal and milk for breakfast, pizza and soda for lunch, cheeseburger, milkshake, fries, a salad for dinner. Which of the following is the most accurate nursing diagnosis based on this data? So if I were to reword this, I would say, what should a nurse tell a pregnant 16-year-old girl who has a terrible diet? Right? That is what this question is about. What sort of diet should pregnant women be following, and what is sort of the bad things that can happen if you don't follow regular diet? So because we know this is priority, let's eliminate anything that has to do with psychosocial. Altered nutrition, okay, that's physiological. We're going to leave that one. Knowledge deficit, psychosocial, take it out. Take it out just like that. I'm not worried anymore. Knowledge deficit has to do with psychosocial, so I'm just going to remove it. Altered nutrition, yep, that's physiological. Risk for injury, yep, that's physiological as well. So, with that being said, now we can go through these answer choices and see if they make sense. Altered nutrition, more than the body requirements related to high-fat intake. Okay, and so when you have a pregnant woman, you want to make sure that they are getting enough nutrition, that they're getting enough, rather than sort of not getting enough. This individual seems to be getting enough, right? And so more than the body requirements related to high-fat intake. She is getting a lot of fat, but when you have a pregnant person, you want to make sure that they're getting plenty of calories. And so here we can take this out. Doesn't make sense. We are already getting enough calories. Altered nutrition, less than the body requirements related to increased nutritional demands of pregnancy. Well, when you're having pizzas, soda, milk, cereal, milk shake, all these things, you're not really getting enough of those green leafy vegetables. You're not getting enough iron. You're not getting enough of those sort of supplemental vitamins and minerals that you need during pregnancy. And so this one definitely makes sense. Altered nutrition, fetal malnutrition related to poor maternal diet. Again, malnutrition has to do with the number of calories. Okay, malnourishment is the number of calories that you're getting. And I think it's safe to say that this pregnant 16-year-old is getting enough calories. And so we can take this one out as well. That's going to leave us with 3. Less than the body requirements related to increased nutritional demands of pregnancy. We are not getting enough iron. We're not getting enough folate. We're not getting enough of our vitamins. This client needs to sort of change her diet probably, as well as start a prenatal vitamin. Okay? Any questions on this one? Wonderful. So let's move on to another select all that apply. Take a moment, read through this question stem, reform it in your mind. What is this question really asking about? And then we'll go through it together. So we have a nurse assessing a client with a diagnosis of rib fractures, okay, to identify the risk for potential complications. Okay, so right off the bat, we need to know what are the potential complications of rib fracture. So I'm going to leave that there for now and let you think about that, and then we'll come back to it. The nurse notes that the client has a history of emphysema. After the assessment, the nurse ensures that which interventions are documented in the plan of care. And so, in order to reword this question, I would say, how should a nurse prevent the complications of rib fractures in a client with emphysema? Okay, and so in order to answer that, I need to know the complications of rib fractures. Okay, and so can anyone tell me one of the possible complications of a rib fracture? This one's a little bit trickier, right? We're kind of asking a second order question here. When you have rib fractures, what happens is when you try and take a deep breath, it hurts. It hurts quite a bit, right? You take a deep breath, those pieces of rib are going to be poking your muscles and poking your nerves. That's not going to feel great. And so when these clients try and breathe, they're not going to be taking deep, deep breaths. They're going to be taking very shallow breaths. One of the risks when you take very, very shallow breaths for a long period of time is that parts of your lung will collapse. We call this atelectasis. Atelectasis. Atelectasis is collapse of your lung tissue. In clients with rib fractures, you have a risk of atelectasis because it's painful to take a deep breath, so your clients don't take a deep breath, and so parts of the lung collapse. Okay. Other clients that are at risk of atelectasis, your post-surgical clients. Those of you that have worked in the hospital know that every single client who goes for a surgery and comes back, they always have a little plastic thing sitting by their bed that we ask them to sort of blow into or take a deep breath through so the little ball can elevate. You guys know what I'm talking about. Why do we have them do that? And why do we tell them to do that 4, 5, 6 times an hour? Because if they are inhaling through this plastic thing, they must be taking deep, deep breaths. And how do we prevent atelectasis? You take deep, deep breaths. With the history of rib fractures, your client's not going to want to take deep, deep breaths. And so one of the priorities in rib fractures is to reduce pain in general. Okay, and so let's, with that understanding, now that we know our question is, how do we prevent atelectasis in a client with rib fractures and history of emphysema? Let's go to our question. Let's look through all of these and see if there's anything psychosocial. Position of comfort. Normally you would think of this as psychosocial, but in the case of rib fractures, this is actually going to be physiological because if they're comfortable, they're not going to be in pain. If they're not in pain, they're going to be taking deep breaths. So we like that. Specimens, physiological. Medication to suppress cough. Suppressing cough as needed. Again, cough is physiological. Small frequent meals, client coughing. So these are all physiological type answers. And so Maslow's is kind of at the window here. We kind of have to go, we have to go with what our understanding of this disorder is. So first, again, maintaining the client in a position of comfort, good. If they are comfortable, they're taking deep breaths. And so we like this one. Okay. Collecting sputum specimens at the hour of sleep. Does this client have an infection? If someone thinks this client has an infection, please let me know what it is, because I cannot see anything in this question stem about an infection. Caitlin and Namrata say no. I agree. Lulu says no. This client does not have an infection. We don't need sputum specimens. Okay, so don't just assume because someone has something lung going on that you need sputum specimens. That's not the case. Medications to suppress cough. Now, initially, this sounds like a good idea, right? We have these pieces of lung fragments moving around, poking us. Every time we cough, that's going to cause a lot of pain. Pain is psychosocial. We're not worried about pain. What I'm worried about, if this client can't cough, then any of the mucus, any of the secretions coming from the respiratory tract cannot make their way out. The whole reason that we're able to cough at all is to get that sputum up out of our respiratory system. Right? We don't want it collecting in the respiratory system. We want it out. And so if we give a medication that suppresses cough, all of those secretions are going to get stuck in our respiratory system, which is going to lead to, you guessed it, atelectasis. And so we are not going to offer medications to suppress cough. We want our clients coughing. Are they going to be in pain? Yes. But we're preventing atelectasis, and so they can deal with that. Small frequent meals, we like this because we don't want them having long meals. We want them to just quickly be eating and keeping it moving. Have the client cough and breathe deeply for 20 minutes. This is, again, something that's very good. Coughing is going to move a lot of that sputum, move the secretions out of the respiratory system, and breathing deeply, again, opens up those airways, prevents atelectasis. So after the pain medication, we want to do that. Administer 4 to 6 liters of oxygen when the pulse ox drops below 90. Oof. This is a tough one. When I'm thinking about my client with rib fractures, I'm thinking that they need to be on oxygen. However, is the first thing that we do to put on 4 to 6 liters, or do we typically start with something lower than that? Caitlin says 2, Lulu says 2, and I agree with them. 2 liters of oxygen is where we start. We're not going to jump straight to 4 or 6 liters just because we see a pulse ox below 90. That's a lot of O2. We're going to start with 2. That's too high. Great. Okay, so the answer choices here we're going to go with answer choice 1, answer choice 4, answer choice 5. Let me click the submit button. Click. Oh, we're on tutor mode, and it says that we got these all right. Very good, everybody. So you can see here, using some of these strategies, it may take a little bit longer. Yes, I'm going to be the first person to admit that. Yes, answering these questions may take you a bit longer, but in the long run, I really think it's going to benefit you because you're really going to understand what's being asked about. You're really going to have that confidence answering these questions because you're not being misled by all of the nonsense BS that they stick in these question stems. Okay? Any questions on these? No? No questions? Number 6 is wrong because of emphysema. Yeah, that's an excellent point, Matilda. So in emphysema, if you give O2, you're going to suppress their respiratory drive. The respiratory drive of clients with emphysema is based upon CO2. If you give all this extra oxygen, you're going to repress their respiratory drive, and they end up not doing so great. So, yes, you're absolutely right. Number 6 is wrong because of emphysema. Very good. So, moving right along into mental health for the NCLEX exam. This PowerPoint is updated from the PowerPoint that I uploaded yesterday. And so if you didn't download it yesterday, go ahead and download it now. You'll have some of the updated slides. There's not any really big differences. If you didn't download it before, you're perfectly fine. The just sort of small changes I made to make some of the slides more clear. Okay. So I had a question, pulse ox below 93, does that require oxygen? That is going to depend on the institution that you're working. Some of them have lower requirements, some of them have higher. Depending on the patient, some have lower, some have higher. I've seen patients in the hospital where they were sitting at 88 and we just let them be there, okay? And so it's really going to depend on the client. There's no strict cutoff. When we talk about ABGs, the partial pressure of oxygen, that absolutely has a normal range, 90 to 100. We don't want to see anything under 90. But for pulse ox and for clients in the hospital, it's really going to depend client to client. In general, once you see pulse oxes going into the low 80s, you need to do some intervention pronto. But in the case of some low 90s, that's usually not anything you can. That's not really anything you need to be worried about in general. But again, it's going to depend on the institution. Okay, good question. All right, so mental health for the NCLEX. What is the deal with mental health? So for the NCLEX exam, what do we need to actually be able to do? Recognizing the signs and symptoms of impaired cognition. I'm talking about delirium. I'm talking about dementia. Recognizing the signs and symptoms of acute and chronic mental illness, as well as the medications we give for that. Recognize the client use of defense mechanisms, behavioral health issues, the client, and last we're going to talk about the client's ability to adhere to the treatment plan. When you give a client a treatment plan, you say you're going to be following up with this doctor on this day, this many times a week, and then the client doesn't do that. Why didn't they do it, and how do we get them on board? Okay, great. So, impaired cognition. Behavioral and cognitive impairments can present as difficulty reading, difficulty writing, understanding speech, some sort of disorientation, feeling lost, not recognizing people, I think is the one that we're most familiar with, becoming lost at places, rambling, not understanding words, poor short-term memory. And so when you have a client with something like delirium or dementia, keep in mind, dementia is not a two-dimensional disorder. We're not just talking about someone who doesn't recognize their grandchildren. We're talking about other types of problems as well. Nonsense speech, difficulty reading, right? The things that these clients used to be able to do, they sort of lose their ability to do when you're talking about dementia. And so be aware of that. Behavioral changes can be there as well. When you're seeing this elderly client with fear, anxiety, depression, or anger, you don't know whether this is their baseline or if it's part of the illness. Keep in mind that the illness can present in many different ways. Agitation, irritability, combative behavior, hallucinations, all of these things can be seen. How do we get impaired cognition? Altered mental status, delirium, dementia, a closed head injury, neurological events like a cerebral tumor or CVA, all of these things can ultimately lead to impaired cognition. And so we're really going to focus on the two big Ds here, delirium and dementia. So dementia, rather than being some sort of biological marker that we can point to and say, this is dementia, dementia is really a cluster of signs and symptoms. When your client presents with those signs and symptoms, we call it dementia. Dementia impairs that client's ability to think, impedes the client's ability to perform normal activities, interacting with others. And so, it really can be debilitating for these clients that have dementia. They go from being a fully functional member of society to not even being able to recognize their own family members. And so it is a pretty serious disorder here. The preventative measures to prevent dementia are not fully understood quite yet. Some people do believe that you can prevent it by controlling their underlying disorders. Hypertension, diabetes. Get those things under control and you will slow the roll of dementia. Consistent daily physical exercise, good nutrition, maintaining a sharp and active mind with brain games, memory exercises. These are the things that are going to really extend out your lifespan a lot longer if you're living with dementia. Okay, and so in terms of education, in terms of counseling for your clients, these are the things that you are going to put priority on is getting the underlying disorders under control and then getting the client involved and interacting with other people. When we talk about dementia and delirium, these are not the same thing. And you'd be surprised how often these two terms get thrown around in the hospital. These are not the same thing. Although the characteristics, signs, and symptoms, they look similar to delirium, dementia is different from delirium in that dementia is not reversible. Delirium is usually reversible and correctable as long as you correct the underlying disorder. Dementia, if this is our mental status, right? If we have our mental status here on the y-axis and time on the x, the mental status in dementia has a slow and progressive decline. Okay, so for dementia, this is what we would see. The mental status just slowly gets worse and worse and worse and worse. In delirium, what you see is if this is the normal mental status, you're going to have a sudden and abrupt change in mental status where your client is becoming confused, not knowing where they are. And then they're going to have a period of clarity. Then they're going to go back into sort of confusion. They may become semi-clear again, become more confused again, become clear again. And so in delirium, you see this sort of waxing and waning course where their symptoms get very severe and then they get better for a little bit. They get severe again, then they get better for a little bit. And so you can see that there's a big difference in terms of these disorders. They're not the same thing. If someone's calling someone who's demented, delirious, they are using the wrong terminology, and you are within your rights to correct them because delirium's correctable. Dementia, these clients have to live for the rest of their life with that. So let's talk a bit about delirium. Delirium is of shorter duration. We're going to have an abrupt and sudden onset. Something is causing this. Some underlying disorder, some underlying problem is causing this delirium. Okay, and so expect to see a sudden onset. Typically not permanent. If you correct that underlying problem, your client's going to go back to functioning. It's going to include intermittent times, vacillating, that means changing between periods of impaired cognition, where they're not too sure what's going on, and periods of mental clarity, where they're back to their normal selves. Treatable and correctable is how we characterize delirium. The possible etiology, some medications. We talked about our anticholinergics. Remember our anticholinergics? Who remembers the mnemonic from yesterday, our anticholinergics? You don't have to type it, but hopefully you can say it out loud, right? If you're in a public place, you don't have to say this because you're going to sound crazy. Hot as a hair, dry as a bone, blind as a bat, red as a beet, mad as a hatter. And so for delirium, we're thinking about the medications. We're thinking about those anticholinergics, giving you that mad as a hatter side effect. Our elderly patient who takes too much Benadryl, our elderly patient who took too much benztropine, who has Parkinson's, right? These things are going to sort of push your client into delirium. Substance abuse, old people, they like to have fun too, and so they mess around, right, with substances. You got to be aware of that. UTIs, infections in general, but especially UTIs. In our elderly patients, whether it's a male or female, UTIs are very common, very prevalent, and can become very, very bad very fast if you, lay delirium on top of it. Our male clients, these male clients typically have a much larger prostate, right? As men get older, their prostate enlarges, unfortunately, and so the prostate is an organ that's right around the urethra. Okay, and so if the prostate gets larger, it can start to compress on the urethra. You can start to have urinary retention because of that, where pee is not leaving the bladder, right? If you have urinary retention, bacteria is going to grow in there. That's pretty much a guarantee. And so in elderly men, you have increased risk of UTIs. In elderly women, you can have increased risk of UTIs as well, because young women have increased risk of UTIs, so do elderly women. Okay, so for our elderly patients, you have to be very careful with UTIs. Say you have a client with a UTI, then they get delirious. Now that they're delirious, they're running around the unit. Now that they're running around the unit, they trip and fall and hit their head. Now they have a brain bleed. Now that they have a brain bleed, they have a compression of their brain things get very bad very fast is the point I'm trying to make here. And so UTIs are very important to treat. You got to identify and treat it as soon as possible, because your delirious patient is going to have some serious, serious problems down the line. Elimination or correction of that underlying cause, supportive care to prevent complications, adverse events are going to be our two mainstays here. Now, what do these Ds have in common? Their treatment. And so, whether you're delirious or you're demented, some things can be, sort of targeting both. Nutritional support, maintenance of safety. These clients are confused. They're running around. They're not sure where they are. Emotional support of the affected client and the significant others. Seeing someone who was, 10 years ago fully functioning, running a company, now completely demented, that's gonna take a toll on the family, right? And so you really want to be aware from a nursing standpoint of both education of what to expect in the case of dementia or delirium, right? As well as sort of counseling them on how to support their client, how to support their family member. So that emotional support aspect is pretty big for nurses. Pain assessment can be difficult. Someone who's delirious, if any of you have worked on, one of these floors with more geriatric patients, it can be difficult to ask about pain when you have someone who is, having difficulty even communicating what their own name is. And so a pain assessment and pain management can be tricky. Look for the non-obvious signs. Prevention of aggressive and dangerous behaviors. This involves limiting the stimuli in the environment. If your client is starting to get agitated, get them into their room. If you can't get them into their room, reduce the number of sort of people around in the hallways. Once you get them in their room, talk to them calmly, talk to them softly. Just always kind of reassure them that they're in a safe place. These are the ways that you're going to prevent those behaviors in your demented or delirious patients. Symptomatic relief of agitation and hallucinations. You got to maintain hydration, especially if you're worried about UTIs. This is one good way to prevent UTIs, is to make sure they're hydrated. Assist these clients with their activities of daily living, making sure that you're doing it in the most therapeutic way possible. Okay, it's better to try and assign the same nurse to these clients every day so you can kind of build a rapport. Once you have that rapport, make sure your client's comfortable. And all of your delirious patients, as well as all of your demented patients, they're not all going to be sort of at the same level of mental functioning. Some of them are going to be, pretty pretty low functioning where they can't even dress themselves or bathe themselves. Some of them are going to be, perfectly high functioning. They just sort of forget their family members from time to time. And so dementia comes in very different forms and flavors. Make sure that you address them at their level of independence. You shouldn't be bathing someone who could bathe themselves, okay, even though they may ask you to. Acute and chronic mental illness. We have 4 broad categories: thought disorders, mood disorders, behavioral, and mixed. But the way that the NCLEX likes to more appropriately categorize them is what they're actually talking about. So depressive mental health disorders, anxiety disorders, bipolar, some of our cognitive mental health, personality mental health disorders we're going to talk about, substance abuse disorders, eating disorders, and our psychotic disorders. We're going to sort of piece through these, talk about what they look like, talk about what are the drugs. This is the question I get over and over again. I have so much trouble with mental health drugs. Not after you finish this lecture, my friend, you're going to be good to go. Starting with our depressive mental health disorders, depression leads to physical, emotional, as well as cognitive signs and symptoms. The way that we screen for depression is using this really helpful mnemonic called SIGI CAPS. SIGI CAPS stands for sleep, changes in sleep, lack of interest, guilt, decreased energy, decreased concentration, changes in appetite, psychomotor retardation, and suicidal ideation. Okay, so these are the things that you're looking for in a client with depression. For sleep, you're looking for changes in sleep. And so you can have a client who's sleeping much more, a client who's sleeping much less. Either way, it falls within this as a positive within this category. Changes in appetite. You can have a client who's eating much more, a client who's eating much less. Either way, you are safe to say that it falls within this SIGI CAPS criteria. Can also be associated with psychotic symptoms, hallucinations, delusions, suicidal ideation, suicide. These are sort of the things that we need to be aware of with our depressed clients. Depressive disorders can be happening with other disorders: schizophrenic, psychosis, substance abuse disorders, anxiety. So substance abuse and anxiety really have strong ties to depression, right? You have a depressed client who doesn't seek out any sort of help. They end up sort of self-medicating with alcohol, weed, you name it. They'll use it, right, to sort of self-medicate and get rid of the depression. But really, you're just sort of feeding into it, and it's only going to make that depression worse. You really need to sort of address the underlying thought processes and issues through therapy. So what sort of therapy? Individual as well as group therapy can be effective. There's also sort of alternative techniques. Progressive relaxation, something called St. John's wort, which is a homeopathic treatment for depression. St. John's wort, for the purposes of the NCLEX, you need to know that St. John's wort is going to increase activity of the P450 system, meaning it's going to decrease blood levels of other medications. If you have a client on warfarin and they take St. John's wort, the level of warfarin in the blood is going to drop. Okay, and so that, in terms of the NCLEX, is something that they definitely want you to know. Light therapy for seasonal affective disorder. Electroconvulsive therapy, very controversial. Only a few places in the country do it, but there are places in the country that still do it because it has shown to be effective. It has shown to decrease symptoms of depression in clients who are resistant to other forms of treatment. Medications, antidepressant medications, SSRIs are commonly used. And so why don't we talk about all of the different... does anyone have questions on the sort of symptoms, signs and symptoms here before we move on to our medications? No? Is everybody keeping up? I haven't lost you all, right? Mental health can kind of drag sometimes, so make sure you're paying attention. This is definitely going to be something that you're asked about on the NCLEX. All right, wonderful. So, I am very sorry. I don't know why this slide looks like this, okay? But to start off, I think if you download the PDF, it doesn't look like this. At least I really hope it doesn't. This is because I kind of merged two PowerPoints together and it looks like crap. But yeah, so this starting off, we have our SSRIs here: fluoxetine, fluvoxamine, paroxetine, sertraline, citalopram. These are indicated for a number of different disorders, everything from depression to generalized anxiety, OCD, bulimia, social anxiety, even premature ejaculation you can treat with an SSRI. Some of the adverse effects of SSRIs, we have something called serotonin syndrome. Serotonin syndrome. This is one of those adverse effects where if you don't catch it, your client can die. Okay, serotonin syndrome. And so usually when I talk about serotonin syndrome, it'll be, yeah, I've heard of that, but I don't really know what it is. So let's talk about our serotonin syndrome before we move on. Serotonin syndrome are symptoms: anxiety, restlessness, disorientation, seeing some autonomic manifestations like diaphoresis, sweating, hyperthermia, hypertension. Look for that high blood pressure. And then neuromuscular hyperactivity. Hyperreflexia means when you tap on the patellar reflex, they try and kick you in the nose, right? Very strong reflexes, muscle rigidity and tremor, and then something called myoclonus. Myoclonus is when you have a sudden spasm of muscles. The way I like to describe myoclonus, imagine when you have hiccups. When you have hiccups, that's like a myoclonus of your diaphragm muscle, right? When you have hiccups, you have just these random spasms that give you that little hiccup, right? And so in someone with serotonin syndrome, you're looking for myoclonus in other muscles of the body, not just hiccups. You're looking for maybe spasms in their arms and legs, sudden movements like this, where they're moving their arms and legs without seeming to control them. What do we do in serotonin syndrome? We're going to admit them to the hospital. We're going to start cyproheptadine. This is an antidote to serotonin syndrome. And we're going to treat the increased blood pressure with beta blockers. Okay, again, serotonin syndrome can kill your client if you do not identify it. If you're a mnemonic type person, I have a mnemonic here for you. The symptoms of serotonin syndrome are harmful. For our H, we have hyperthermia with a high body temperature. A, delirium, confusion, agitation. R, reflexes for our hyperreflexia. Myoclonus is our jerking and twitching of muscles. Fast heart rate for F. Unconscious, they can go into a coma, which is why we have to be very careful about this. And then loss of GI control, giving you that nausea and diarrhea. Okay, any questions on serotonin syndrome? If you have heard the term serotonin syndrome in the past, but you never knew what it was, can you go ahead and raise your hand for me? None of you have your cameras on, but I'm assuming you're all raising your hands. Okay, great. So hopefully this has been a nice sort of introduction into this disorder, because again, this is something where if you don't see it, you're not going to know it's there. Okay, so look for someone with a history of taking SSRIs. Our SNRIs, instead of serotonin, we have norepinephrine, venlafaxine, desvenlafaxine, duloxetine, indicated for many of the same disorders as SSRIs. Here we're looking for an increase in our blood pressure, some stimulant effects, as well as sedation and nausea. So nothing too fancy there in terms of our side effects. For our TCAs, look for names like triptyline, amitriptyline, nortriptyline, imipramine. These drugs used to be the go-tos for depression before the SSRIs came out. They have a number of different side effects. Sedation, they have alpha-1 blocking effects like low blood pressure, and there's also anticholinergic side effects. However, we went through anticholinergics together, so I don't even need to list these for you, right? You already know these, but I will list them because I care. Tachycardia, urinary retention, as well as a dry mouth. Okay, and so because of there were all these side effects, we went and we developed new depression medications, and they stopped using TCAs for depression anymore. But you know, these pharmaceutical companies love to make money, and so they sort of did some research and they found out that it can be used to treat some other problems as well. And here I'm talking about peripheral neuropathy, chronic pain, thinking about our clients with diabetic neuropathy in their feet. If you give TCA, that will treat a lot of those symptoms. Okay, and so it can be helpful for clients with those particular problems. Our MAOIs, phenelzine, selegiline. These are, again, depression medications that used to be used a lot. Not used too much anymore because of SSRIs. Still sort of used for Parkinson's disease a little bit. In terms of our side effects, there's two big side effects for our MAOIs. Number one is going to be something called hypertensive crisis. If you have a client who is taking this drug, say phenelzine, and then eats something called tyramine, their blood pressure is going to suddenly rise very, very high. I'm talking 160s, 170s for the systolic. And so what is tyramine? How do you even know if you're eating this? Tyramine is found in wines, as well as aged cheeses. Aged cheeses, okay? And so I always think of this as the wine and cheese party effect. If you have someone taking this antidepressant, they drink some wine, they eat some aged cheese, they're going to end up with a very, very high blood pressure, and they're going to end up in the emergency department, okay? And so that's one thing to be aware of. Another thing that's particularly important is this contraindication with other serotonin medications. TCA, St. John's wort, because you're worried about serotonin syndrome. MAOI combined with an SSRI has a risk of causing serotonin syndrome, so you never want to combine these two. In fact, you want to wait 2 weeks after stopping MAOIs before starting anything that increases your serotonin. Okay? Any questions on these medications? Anything you want me to go over one more time? Everything makes sense. Serotonin syndrome, you guys are okay with this? Yes? Wonderful. So moving into our anxiety disorders here, we have our acute stress, post-traumatic stress, separation anxiety, as well as obsessive compulsive, specific phobias, and we're going to talk about how to treat these. This is what the NCLEX asks you about, is how to treat phobias. Panic disorder, as well as generalized anxiety disorder. So for our anxiety disorders, first is our acute stress disorder. This is going to have something that sort of sets it off. There's going to be an event that starts this disorder happening. After that event, we're going to see anxiety, detachment, numbness with indifference, and it's typically going to last no longer than 1 month. Okay, so look for some symptoms of anxiety, but look for those symptoms to go away after a month. Our post-traumatic stress disorder is when you have those symptoms and they persist for longer than a month. Okay, and so here we're looking for nightmares, fear, night terrors, social isolation, and so you're going to have those anxiety symptoms plus physical responses, tachycardia, diaphoresis, nausea. Those physical symptoms are very typical in PTSD. Okay, these things can persist for years, and sort of those memories of the event can really persist for a long, long time. Obsessive compulsive disorder is the signs and symptoms are hoarding, preoccupation or urges, thoughts. A lot of times when we talk about OCD, we always talk about these sort of neatness and these organizing symptoms, the needing to lock and unlock the door. We usually focus on these physical things that the clients do. But what I'd like you to know is that a very important part of OCD is the thoughts that these clients have. The reason that these clients do this organization, these bizarre things, is to push away thoughts. One of the ways that I've seen it asked about on the NCLEX is they will describe for you a client who is, say, working in a fast food restaurant, who has, never had any history of violence, never, grew up in a happy home, all this kind of stuff, but keeps having these recurrent thoughts of wanting to injure his coworkers, right? And so in order to get rid of those thoughts, the client doesn't want to injure their coworkers, they just keep having thoughts of it. In order to get rid of those thoughts, the client does all of these sort of compulsions, and by doing these compulsions, locking and unlocking doors, turning lights on and off, it sort of pushes those compulsions away. Okay. Separation anxiety disorder is when the client has high anxiety when separated from a person from who they have a lot of attachment. So this is sort of the thing that you really see more commonly in children, especially right after they start school, when they're away from their parents for the first time. That's your separation anxiety disorder. Our phobias, specific phobias, they can be something like a social phobia, where you have anxiety and stress about being, in situation with others. Agoraphobia, being afraid of being away from the home. Fear of spiders, airline travel, heights, or clowns. And so the way that, what you need to know for the NCLEX is that the way you treat these is with immersion therapy. The way to treat phobia is to expose the client to whatever they're afraid of in sort of a scheduled way or a stepwise way. And so for the example of airline travel, say you have a client who has a phobia of airline travel. They don't want to get on a plane. They're so scared, but now they get a job where they have to travel. how do you treat that phobia? How do you get them to be able to get on the plane for their job? You're going to do exposure therapy. So what you're going to do is you're going to have the client on day one drive by the airport, right? Not go inside, not park. You're just going to drive by the airport, look at it, and keep on moving. Day two, you're going to park at the airport, sit in your car for a few hours, and then leave. Day three, you're going to park your car at the airport, you're going to take your bag, and you're going to go into the terminal and just sit in there for a little while. Day four, you're going to shop at one of the stores in the terminal, so on and so forth. And so you're going to slowly, stepwise, get them to the point where they are more comfortable with being on a plane. And that is how our immersion therapy, yep, sensitization, exactly. That's how it goes. Yeah, sensitization. You're sensitizing them to the experience, and so that they don't have that phobia any longer. That's the way that works. Okay. Panic disorders, panic attacks, temporary but severe anxiety, chest pain, palpitations, shortness of breath, inability to swallow and breathe normally. So look for a lot of those physical symptoms. If you have someone who says they're having a panic attack, you definitely want to ask about what sort of physical symptoms they're having. Generalized anxiety disorder. The way you describe this one is you have a client who's anxious about most things most of the time. Okay, persistent and ongoing excessive worries that continue for a duration of more than 3 months. They're worried about most things most of the time. That's how we describe GAD. And so treatment for these different disorders are going to differ and vary among different individuals, as well as they're going to differ disorder to disorder. And so some of the medications, however, that we do give, I'm just going to skip ahead a slide to show you some of these different medications. You'll see that for GAD, obsessive compulsive, panic disorder, all of these things are going to be treated with our SSRIs, okay? SSRIs. A lot of these stress disorders, you can really just throw an SSRI at them and they're going to feel a lot better. Bipolar disorder, here we have periodic episodes of mania and depression. What exactly is a manic episode, right? You hear people describing, oh my God, that girl, you know, she's so bipolar, she's so crazy, she's so bipolar. What does that actually mean? What is a manic episode? When you have a client in a manic episode, they are impossible to control. Wild flights of ideas saying, you know what, today I think I'm going to try and sign up for law school, and then after that I might start my own company, right? Thoughts of these wild flights of ideas. Restlessness, needing to move around, agitation, euphoria, feeling like you can take on the world, a lack of good judgment. This can be shopping for things online that they can't afford, or going to the casino and gambling, sort of having reckless encounters with people. This lack of good judgment is part of a manic episode. These clients will be able to go all night without sleeping and still have energy. Impulsivity, delusions of grandeur. They may even have hallucinations. And so you can see a manic episode is not someone just sort of being excited about life. If you have a client in a manic episode, typically this person will need to be hospitalized. They will need to be hospitalized because they are sort of a danger to themselves and others. If they are spending all of the money in their savings account on gambling, they're a danger to themselves and others. And so a lot of times in manic episodes, you'll need to hospitalize. That's the way you should think about manic episodes, is this client cannot be sort of in the milieu, out in the world. For our bipolar disorders, we've got two types. Well, three types really, but type 1 bipolar disorder, all you need to get that is one episode of mania and one episode of depression. One episode where you're having these wild flights of ideas, and then one episode where you have all of the signs and symptoms of depression that we talked about. Those SIGI caps from earlier, all those signs and symptoms will be there. For bipolar 2, the difference between bipolar 1 and bipolar 2 is really how manic your client gets. In bipolar 1, we have a true manic episode. Bipolar 2, we have something called hypomania. Hypo means less, right? And so our clients that are hypomanic, they have similar symptoms to these manic episodes, right? Really excited about life, lots of energy, but they're not quite severe enough that you would need to hospitalize them. They may be spending a little bit more money on things they don't need, but they're not gambling at all at the casino, okay? And so hypomania is like mania, just not quite there yet, if that makes sense. And then you'll also see episodes of depression with that as well. For cyclothymia, here we are looking for a persistent minimum of 2 years in which we're going in between hypomania and mania, and lots of depression during that time as well. Our treatments of this, if it's a manic episode, maintenance of a safe environment, protection of the client's safety, aka hospitalization. This is how you're going to protect them during that manic episode. Individual group therapy, and then you're going to need to start medication therapy as well. Any client with bipolar needs to have medication therapy. And so you're going to start off with a mood stabilizer. Typically you'll use lithium. You can also use valproic acid, carbamazepine, lamotrigine. Some of these anti-epileptic type drugs can be useful in the case of bipolar disorder. Anxiolytic, if they're having a lot of anxiety, you can reach for one of the benzodiazepines. Benzodiazepines need to be used for a short period of time, though, because of that risk of dependence. And then SSRIs eventually is what you'll move to. Okay. And so we discussed some of our anxiety meds here. Bipolar disorder, we're adding to that. Our social anxiety disorder, as well as Tourette's. Okay. Wonderful. So moving into our personality disorders. Personality mental health disorders. They're classified in terms of their characteristics, in terms of a cluster. All the cluster tells you is that these separate disorders sort of have similar characteristics. However, just because you have schizoid personality disorder does not mean you're also going to have paranoid. That's not what it means. It just means that some of the characteristics about these disorders are somewhat similar. And so for our cluster A, we have schizoid, paranoid, and schizotypal. Cluster B, narcissistic, antisocial, histrionic, and borderline. In cluster C, dependent and avoidant. Schizoid should not be here, right? That's a mistake. Just dependent and avoidant are our cluster C. And so let's get into it, talking about these different personality disorders. Schizoid personality disorder is indifference, detachment, lack of close interpersonal relationships. This is a client who is really much of a loner, who doesn't have people that are close to them, but they are okay with that. Schizoid, they are okay with being alone. They're going to try and confuse you with one of the other personality disorders where the people don't like being alone. Schizoid, they like being alone. And so the way that I always remember this is I write out schizoid, and I put a giant O. Okay, schizoid. And then on top, I write alone. Okay, schizoid clients like being alone. Okay. Just because it says schizo in the start, don't think schizophrenia. It has nothing to do with schizophrenia. This is a personality disorder, a client who likes to be by themselves, likes to be alone, and has no close personal relationships and is perfectly okay with that. They live alone, they have no pets, they're just really loners, and they like that. Our paranoid personality disorder, these are a distrust of others, suspicions. If you have a client who every time you give them meds, they say, what is that? What are you giving me? Is this a different pill? Why does it look different? Right? That's a paranoid personality mental health disorder. Our schizotypal personality mental health disorder is eccentric thinking, behaviors, hallucinations, and delusions. These are our magical thinkers, people who, believe in the zodiac calendar very strongly, people who think that fairies are real and living among us. These are people who have more magical thinking. And so they're not necessarily living alone, right? This is not schizoid. This is schizotypal. They may be married, they may have 25 cats, that's fine. They're schizotypal, and I want you to think of this as a type of schizo, right? A type of schizo, meaning someone who's a little bit odd, a little bit weird, and sort of has these weird beliefs and feelings, okay? That's our schizotypal. Narcissistic, here we have delusions of grandeur, really feeling like, really self-obsessed, right? Narcissistic is self-obsessed. They don't really care about others' feelings, lack of empathy towards others, being arrogant, need for praise and esteem by others. We all know at least one of these in our lives, I guarantee it. And so for the narcissist, this is what you're looking for. Antisocial personality disorder. I know most of you have probably at least once in your life either said yourself or had said about you, why are you being so antisocial? You're not talking to me. That means you're being antisocial. I'm here to tell you that that is not what antisocial means. Antisocial is when you have someone who does not accept responsibility for their actions. Meaning, this is someone who will steal an old woman's purse and not feel bad about it. This is someone who will set fire to the church and laugh, right? Indifference for others and their needs, exploitation of others, illegal actions. A lot of antisocial people are locked up because they commit crimes. They don't care about, what are the laws? How is this going to make someone else feel? Antisocial means, a lot of people call these sociopaths. They don't care about the laws. They don't care about society. And they don't really feel bad about the things that they do. All right? So when you think antisocial, don't think, oh, you went to a party and sat in the corner. Think, oh, you went to the party and then you set the record player on fire and then you tossed whoever's party it was in the pool, right? So antisocial means you are disrupting sort of the societal norms. Histrionic personality health disorder, flirtation, seductiveness, attention-seeking behaviors. I want you to really think about your dramatic client here. Drama in big letters. These clients are very dramatic. They chip their nail and now they're crying, right? This is the type of person that you see with histrionic. Borderline personality disorder, we're looking for impulsiveness, ego weakness, exploitation of others. These are very difficult clients to deal with in the hospital. If you've ever had a borderline patient, you are probably saying amen to that, because these clients are manipulative. They will attempt to sort of manipulate the unit rules, manipulate you to break the unit rules. And I see a lot of questions on borderline on the NCLEX. You probably have as well. The key to these clients is you have to stick to the rules. You have to be firm and you have to not make exceptions for them. Okay? You got to be firm and not make exceptions. Do not allow, the rules to be manipulated because of these clients. Okay? Dependent personality disorder. Here, these clients are very dependent on someone else. They're not able to sort of make decisions on their own. Avoidant personality disorders. These are clients who are very alone. They don't have close social relationships. They don't have close contacts. They don't live with anyone. And so that's how we describe those. And so I know what you're saying right now. Whoa. Aaron, you just said on the last slide that schizoid is people that are alone, not avoidant. You're absolutely right. Schizoid people with schizoid personality mental health disorder, they like being alone. They like being on themselves. They like not having close personal relationships. Avoidant personality mental health disorder, they do not like being alone. But because of their own fears of criticism, because of their fears of rejection, they have a hard time maintaining social relationships. Okay? They have a hard time making friends. They have a hard time being, part of a group. In avoidant personality mental health disorder, they want to have connections, but they can't make them. Okay? The NCLEX is going to get you to try and confuse those two. Okay? So when you think schizoid, think alone. They like being alone. Versus avoidant, they are sort of avoiding situations because they're afraid of being criticized, but they want to be there. Okay? Any questions on these? You guys think you got it? You got a good understanding here about what every single one of these is? Or at least you can study it and get a better understanding. So what I'd like to do next, this is not what the NCLEX is going to have you do. This is just sort of a bit of fun. I'm going to show you a picture, and then I'd like you to make your best guess about what mental sort of personality disorder this client has, okay? And so we're going to start with this particular client. What personality mental health disorder do you think she might have? Again, this is just for fun. This is not something I would encourage you to do sort of to your family members, but just for fun and to sort of cement your understanding. We have someone here acting very dramatic. Maybe she just, dropped her fork on the floor. She was having dinner. Histrionic. Excellent. Yep, histrionic, very dramatic, needs attention, and so we'll kind of play up everything that's going on. So this is our histrionic. Very good. Next one. This guy's really, really looking at the one he truly loves and feels pretty good about it. Probably doesn't care whether or not you need to use the mirror right now, right? Not a lot of regard for other people's feelings here. If you have someone who is very obsessed with himself, we are thinking narcissistic. Yes, narcissistic personality. Good. Next, we have someone here Looks like she's got a wizard's cap on. She's got the eye in the pyramid, the Illuminati thing. We've got a little lamp that is a planet. That's actually kind of cool. I kind of want that. We've got mismatched socks, which I never noticed before, but the socks are not matching. And then we've got a crystal ball here. Caitlin says schizotypal. I agree. Yes, very good, Spencer. Schizotypal here. Very odd thinker. You know, thinking about, you know, magic and Harry Potter and these types of things and thinking that's all real. Not paranoid. So a paranoid, I'm glad you said paranoid, because what I want you to understand about paranoid is that you have an underlying mistrust of others. Okay, so that's more of an aggressive type personality, right? If you have a paranoid personality disorder, you're very suspicious of people. You get angry very easily. In a paranoid personality disorder, we're really looking for an underlying aggression and an underlying distrust. Versus schizotypal, I mean, this lady just wants to, you know, sort of play with her crystal ball and go to bed, right? We're not a lot of sort of underlying anger here, all right? And so for this one, all the above, right? Great. Okay, so we're not going to get political. Moving right along. So personality disorders, what do we do for treatment? It varies. Depending on the disorder, the intensity, the client's responses, client's coping, it's going to be different depending on the disorder. Most of these disorders, clients will live with their whole life, right? Thinking about our schizoid clients, they're not going to you to seek out help, right? Most of them are just sort of living their lives. And so if you do have someone, you know, who is seeking out treatment, you can look for the mood stabilizers, antidepressants. But again, most of these clients don't really seek out treatment. Moving into our substance abuse here, alcohol is sort of our classic, you know, substance available, you know, to anybody over the age 21. Illicit drug abuse, and then impulse control disorders, sexual addiction, compulsive gambling, internet addiction. All of these things can fall within substance abuse, and you know, need to be sort of addressed for any client where it's really significantly impacting their life. For our eating disorders, we have three eating disorders we have to discuss: anorexia nervosa, bulimia nervosa, and binge eating disorder. All of these disorders have one sort of common underlying feature, where when the clients look in the mirror, they are really sort of focusing on something that may not be there, right? If you have a very skinny client looking in the mirror and thinking that they are not the way that they look, this is what sort of drives some of these behaviors. Is something called body dysmorphia, believing something about your body is wrong, or that you need to correct it. Okay. And so anorexia nervosa, typically when we talk about our anorexics, we're looking for more of a skinny client, a client who is restricting their food or having some sort of purging behaviors where every time they eat, they vomit up what they eat. Look for low body weight, obsessions with food. You can see erosions in the esophagus and along the teeth because of vomiting. These are some of the things you look for. And bulimia nervosa, here we have binge eating. That's usually followed either by purging with vomiting or using laxatives, enemas, things like that to get the food out of the body. The big difference between bulimia and anorexia is typically bulimics are of a normal body weight or can even be slightly overweight. Okay. For our binge eating disorder, here we have repeated consumption of large amount of foods, but without any sort of purging. Okay, and so these clients are just only going to basically gain weight. This disorder is ultimately always going to lead to obesity. Okay. So, in terms of treatment for these disorders, the one that's probably most relevant for the NCLEX is how do we treat someone who's been food restricting in anorexia. If you've been food restricting in anorexia, you have to think about some of the physiological changes: heart disease, impaired renal and hepatic functioning, dehydration, and then the electrolyte imbalances can be huge. Hyponatremia, hypokalemia, hypochloremia. These changes have serious health risks, and one of the important keys of if you have someone who has been restricting food, when you start to try and give them food again, you need to do it slowly. Restoring levels of electrolytes needs to be done carefully and slowly so that you don't start having arrhythmias, you don't put your client into a coma. Okay. In terms of treating these disorders long term, psychological interventions like a therapeutic milieu, Really the goal is to increase that feeling of self-esteem, that feeling of self-worth. Okay? Great. So our psychotic disorders, we have a good number of them. Schizophrenia, delusional, schizophreniform, brief psychotic, schizoaffective, substance abuse. And so for the NCLEX, you don't really have to know too much about the details of these. In general, the way that we talk about these is we classify them by how long you've had it, but you don't really need to know those classifications for the NCLEX, right? Hallelujah. One thing you don't need to know. But we will briefly describe what we can see in these disorders. So there's 4 broad categories. There's cognitive symptoms, affective symptoms, positive symptoms, and negative symptoms. So for our cognitive symptoms, these would be deficits in memory, poor attention span. You're thinking about things that are cognitive, right? Lack of concentration, poor decision making, inability to solve problems. For our affective symptoms, we're looking for thoughts of suicide, hopelessness. This is our affect, right? This is how we feel on a day-to-day basis. Our positive symptoms, these are things that we're adding to the experience. A positive symptom is something like hallucination, delusion, bizarre behavior, things that are not normal are things that you see for positive. Our negative symptoms are a flat and emotionless affect, lack of energy and motivation, and an inability to verbally communicate. Okay, so negative symptoms are things you're taking away from the client's ability to interact with the world, and positive are things that you're adding into the client's sort of perception. Okay, that's what should be positive and negative. Some of the medications are asked about on the NCLEX. We have 2 categories here. Typical and atypical antipsychotics. How do these work? They block dopamine receptors. The important thing for the NCLEX are some of these neurologic side effects, extrapyramidal symptoms, anticholinergic symptoms. For our atypicals, we really look for more of metabolic type side effects. Weight gain, blood glucose increase, hyperlipidemia. And for clozapine, you have to keep an eye on the white blood cell count because it can drop if you have a client taking clozapine. Okay, and just sort of adding to this list, for our alcohol withdrawal, we do want to use benzodiazepines. This can be useful both with the withdrawal, as well as if you have a client who has some sort of seizure related to the withdrawal, this particular medication can help with that. Okay, and so getting into our stubborn clients, just because you have your client explain the treatment plan to your client doesn't mean that they are going to be compliant with it or adhere to that treatment plan. And so there are factors that can impact the client's compliance. Say that 5 times fast. Broadly categorized, we have therapy-related factors, patient-centered factors, healthcare system factors, social, economic, as well as disease factors. And so, for our stubborn client, if they are not participating in designing the treatment plan, they're not going to really feel super inclined to follow that treatment plan. So in order to sort of get around this, involve them in aspects of the treatment plan. If you're telling your client they need to take the same medication every day at 8 a.m., but they are at their desk at work at 8 a.m., that's sort of showing the client that you didn't involve them in the treatment plan. And it's going to be a barrier to them being able to keep up with their treatment. And so involve them as you're making the treatment plan, and you're kind of overcome this particular obstacle. There's this idea of locus of control. Everyone has one of these. You either have an internal locus of control or an external locus of control. If you have an internal locus of control, you're someone who's motivated to learn about your disorder, to follow your treatment plan. You're in this class today. I tend to think you have an internal locus of control. You have control of your future, your health, your wellness. You have an internal locus of control. Some clients are going to feel that they have an external locus of control, meaning that there is something outside of them, be it God, Allah, whatever it is, something outside of them is sort of predestining their future. And so they sort of feel that they don't really have control over their future, their health, their wellness. They can't really do anything to change their fate in terms of their health and other aspects of their life. And so that's unfortunate. And by the time that you're seeing this client, what can you do to get around this? Really, your best goal is to provide that client with support, positive reinforcement, and get them into a peer group, a peer support group. They're going to see other clients who have the same disorder, who are doing something about this, and who are doing better than they are. When they see that, typically they are going to want to sort of get with the program and start following along with the treatment protocol. the client's level of self-efficacy. So your self-efficacy is whether you have sort of a I can do it attitude or I can't do it attitude. Okay, that is what your self-efficacy is. If you have a high degree of self-efficacy, that means that, you know what, whatever the problem is, you feel that you can sort of overcome it. Think about the NCLEX exam, right? Whatever that problem is, you're attacking those problems with this attitude of, you know what, whatever this question is, I'll be able to answer it. If you have a client who does not have that attitude, again, get them into a peer support group and give them some positive reinforcement. For denial, many clients will struggle with denial. They don't really believe that they have a certain illness, or they don't really believe that there's a cure out there. And so here it's really about reinforcement. Educate the client about continuing the treatment plan, continuing their medications, even though they're feeling better. The cost aspect of treatments is something that you're not going to know about unless you ask about. Most clients are not particularly proud to tell you they can't afford their $30 blood pressure medications because they can't really afford to buy groceries, right? And so you got to ask about this. If there is some sort of cost barrier to treatments, there are things we can do, right? There's social work, there's different drug companies will offer coupons for their medications. There are resources we can connect them with, and so make sure to ask about that if you have a stubborn client. The nature of the treatment plan should be at the level of the client's understanding. Don't make it too complicated and difficult for the client to follow. Some of your clients you're going to have graduated with PhDs. Some of them barely made it through middle school, okay? And so make sure that the treatment plan itself is sort of geared towards their level of understanding and make sure that it's not sort of too difficult or cumbersome for them to follow. Side effects can be unpleasant and can result in your client not wanting to take their medications. Thinking about our clients who are taking things like thiazide diuretics for high blood pressure. They're running to the bathroom every 15 minutes. Clients don't like that. And so if there's another drug we can give, maybe an ACE inhibitor, fewer diuresis type side effects, that may sort of help the client. We have to be aware of that. Apathy. Some clients, even after they understand their treatment plan, they just don't care enough to comply with it. Okay, it's very challenging to get through. You got to address it. Previous negative experiences. This is one that is on the NCLEX pretty often. You have an angry client who says, you know what, I have been waiting here for an hour and a half. Last time I was here, the doctor gave me a medication and I felt horrible the next day, yada, yada, yada. Do not confront this client. Let them vent all of the issues that they think are so important. That's fine. Let them ventilate that all out. Say, I'm very sorry to hear that. Let me tell you why it's going to be a little bit different today. Let me tell you what we're going to do for you today. These are sort of the things that you can help with your client that comes in very angry with those negative experiences. There are some cultural, religious, spiritual conflicts. I do see questions on this from time to time. Things like Jehovah's Witnesses cannot receive blood transfusions. If you have someone who's of the Islamic faith, typically if you have someone in their family that's dying, their bed should be pointing towards east. So things like this, you want to be aware of sort of how someone's culture, how someone's religion influences their care. If it's a barrier to their treatment, you need to identify the conflicts first, and then work with the healthcare provider as well as some possibly even spiritual staff to figure out what's going to work in terms of the treatment plan. Substance disorders, psychiatric mental health issues, these things can obviously be barriers. You have to encourage your client to accept the treatment for the substance abuse, and just give them all the information possible. Okay. Excellent. And so that's going to be about it for mental health. I'm glad that you all were able to stick with it today. It is a sort of a dense topic, but it's definitely something that gets asked about quite a bit on the NCLEX exam. Okay? And so thank you again. I'm happy to see you all. I will be sticking around for another about 30 minutes. If you have questions, stick around with me and ask. Otherwise, I will see you tomorrow at our normal time and normal place. All right? Thank you, everybody. Have a great night.